Hi all, my name is Natalie Reyes and today I'll be discussing the West African 2014 and 2016 Ebola outbreak. This outbreak of global health importance was chosen as it was considered a major humanitarian crisis due to its rapid spread, severity and secondary effects on health systems and community health status. The Ebola epidemic caused global panic and its response was criticised as too little, too late. The next slide shows the outline of this presentation. Ebola virus disease, formerly known as Ebola hemorrhagic fever, is a rare but severe illness and often fatal in humans. The virus is thought to originate from fruit bats and transmitted to humans from infected animals. Ebola then spreads in the human population through human-to-human transmission via direct contact. The incubation period is from 2 to 21 days and it is only contagious once symptoms develop. Acute clinical symptoms include fever, fatigue and headache, followed by vomiting, diarrhea, rash and in some cases internal and external hemorrhaging. Average case fatality is approximately 50%, however often difficult to quantify due to screening and detection issues. Furthermore, vulnerable populations such as those with comorbidities, the elderly and those with low socioeconomic status are more prone to death. Early supportive care with rehydration and treatment of symptoms is crucial in improving survival. Finally, as of 2020, 2 antibody drugs and 1 vaccine has been approved for treatment and prevention, which has seen outbreaks much more manageable. When looking at any disease or outbreak, it is important to look at the history. The first recorded outbreak was in 1977, with approximately 20 outbreaks documented since then. Previous outbreaks typically killed 50 to 100 people and were limited in time and contained to rural areas in Central Africa. The 2014-2016 West African outbreak, which will be the focus of this presentation, was different from previous outbreaks and is encountered to have killed more than 11,000 people. Despite the genomic structure being nearly exactly the same as previous ones, social and human factors have been attributed to the rapid spread of the disease. This highlights the importance in recognizing the One Health approach, which acknowledges that interactions between humans, animals, and ecosystems have changed and continued to change at an unprecedented rate, resulting in the emergence and amplification of infectious diseases. Studies suggest that case 0 was an 18-month-old boy in a remote village in Guinea who developed Ebola symptoms on the 26th of December 2013 and died 2 days later. It is interesting to note that this small remote village with only 31 households is located in what is known as the forest region. However, most of the surrounding forest has now been destroyed by foreign mining and timber operations. Some evidence suggests that these effects of deforestation have brought infected animals and bat species in closer contact with human settlements, thus making transmission much more likely and highlighting the interconnectedness of health. By the second week of January 2014, several members of the boy's family and the healthcare workers who treated him developed symptoms and later died. During the following week, extended families who cared for the sick or attended funerals suffered the same fate. On the 24th of January, this rapid chain of transmission involving 4 sub-districts raised alert to local health officials. And by the 13th of March 2014, the Guinea Ministry of Health alerted an unidentified disease with the WHO's Regional Office for Africa, AFRO. This led to the formal opening of an emergency management system event for a disease suspected to be Lassa fever. On March 14, staff from the Ministry of Health, AFRO and MSF, Médecins Sans Frontières, began investigating epidemiological links and the source of the index case. During this time, the disease was still unknown. Delay in identification has been attributed to the fact that Ebola had not been a threat in West Africa prior to this outbreak. Nearly 3 months after the case, on March 22nd, the causative agent was confirmed as Ebola virus disease. The next day, it was confirmed that the causative agent was the Zaire species, being the most lethal virus in the Ebola family. On that day, WHO publicly announced the outbreak with 49 cases and 29 deaths officially reported. At this time, it was acknowledged that Ebola had spread into Liberia and Sierra Leone via land travel, which is a common practice in these highly mobile populations. The outbreaks in all 3 countries began to smoulder and transmission increased to a point where they could no longer be traced. Following this, on the 28th of March, GORN deployed to Guinea to further investigate. Nearly a month later, the MSF declared a second wave of Ebola and called for global response as they criticised the WHO's delayed action. On the 20th of July, the first international air travel transmission was identified coming from Liberia into Nigeria, causing international concern. On the 9th of August, the WHO announced a public health emergency of international concern to address Ebola in accordance with the international health regulations. On the 28th of August, the Ebola response roadmap was issued with the goal to stop transmission in affected countries within 6 to 9 months and prevent international spread. Following this, the United Nations Mission for Ebola Emergency Response was created. The UNMER was the first time the UN had taken direct control over management and control of an international health crisis. It was finally closed on the 31st of July 2015. The remaining of this presentation will look at the results of a systematic literature search to evaluate the Ebola response in West Africa. By using the five strategic priorities known as STEP, developed by UNMER, each criteria will be analysed to identify their successes and weaknesses and use the lessons learnt to improve and recommend responses for future epidemics. When UNMER was established, it was clear that the Ebola outbreak was spreading at an unprecedented rate and had outstripped the capacity of governments and international responders. It was a unique and one-of-a-kind approach to global health outbreak with the objective to greatly increase the scale and coordination of the international response and to facilitate its logistics. The UN-led response was based on the international health regulations and contributed to global public health security by providing a framework for coordination of management events and improving the capacity of state parties to detect, assess, report, and respond to the public health risk. The overall goal of country implementation was to limit the spread of health risks to neighbouring countries and to prevent unwarranted travel and trade restrictions. UNMER devised individual response plans for each of the 3 countries modelled on the WHO roadmap. It encompassed the following 5 strategic priorities: stop the outbreak, treat the infected, ensure essential services, preserve stability, and prevent further outbreaks. Before I start this analysis, it is important to note that the UNMER strategic STEP framework began very late on within the outbreak, and thus numerous challenges surrounding the context and the previous vulnerabilities which were already in place impacted overall outbreak management and are listed on this slide. The first pillar of the STEP framework is to stop the outbreak, which includes identifying and tracing people with Ebola and undertaking safe and dignified burials. According to a report by MSF, identifying and tracing people with Ebola was a key challenge as chains of transmission remained active even after the initiation of UNMER. It was found that misconceptions of Ebola were widespread and stigma was intense, leading to avoidance in seeking treatment or reporting cases. It was noted that people who had been in contact with the sick were fleeing into the bush so as not to be traced as a contact or taken to a case management facility, fearful of what may happen. Following the first phase, reports showed that survival more than doubled in Ebola treatment centres. However, patients frequently refused to travel substantial distances for treatment, and as cases declined, complacency and Ebola fatigue appeared in some populations. Furthermore, other activities that were required but failed to identify cases included surveillance systems and laboratory services, especially in remote and rural areas. Barriers included poor health infrastructure, lack of basic equipment, and lack of essential items, ranging from transport to mobile phones. The WHO and the MSF both found that the lessons learned included the need for further awareness raising, community engagement, and improved access, distribution, and coordination of resources. In regards to safe and dignified burials, according to WHO, all countries had significant capacity to bury the deceased in a safe and dignified manner. However, this did not deter communities hiding deaths and undertaking safe burials. Community focus groups criticised agencies for not allowing elements of spirituality to be included and refusal of cultural sensitivity. It was only in November 2014 that the WHO introduced a new protocol for safe and dignified burials with advice and consultation from both Christian and Muslim community leaders. This was a response to mounting evidence that a failure to respect these traditions was a major reason why patients continued to be cared for in homes and bodies continued to be buried unsafely and in secret. Following this implementation, by December 1, targets of 70% safe burials and new patients with Ebola in treatment facilities was achieved, thus highlighting the importance of cultural and religious humility and community engagement in future epidemics. The second pillar of STEP includes treating the infected, which encompasses both persons with Ebola, medical responders, and infection control practices. Ebola transmission occurs through direct contact, and thus case clusters are commonly found amongst people caring for the ill. Some of the issues surrounding this included poor knowledge of the disease, especially in regards to infection control practices and when disposing of the deceased. Shortage of personal protective equipment, PPE, left an already weak and under-resourced health system vulnerable to high transmission between healthcare workers and within hospital settings. Furthermore, due to the climatic factors, healthcare workers were seen either not donning PPE correctly or suffering heat stroke. By the end of 2014, 850 people had been infected in Guinea, Liberia, and Sierra Leone, with more than 50% dying from the disease. To make matters worse, in Sierra Leone and Liberia, workers went on strike when their employees failed to pay them or provide them appropriate gear and equipment. The Ebola outbreak exposed health system fragilities, poor infection control put health workers at risk, and dissuaded patients from seeking treatment. Community-based health workforces were insufficient and therefore unable to detect unusual symptoms or patterns, educate the community or trace contacts, and public distrust reinforced rumours impeding behaviour change. On the 31st of October, the WHO, in collaboration with a large group of experts, updated the guidelines on PPE to acknowledge heat-associated stress. Equally, education and standardisation of practices took place. The Ebola epidemic taught us that the recommended public health capacities required under the IHR, but widely ignored, are crucial in bringing health emergencies under control and keeping populations healthy and safe. Overall lessons included the importance of strengthening healthcare systems, education, standardisation of procedures, and importance of governance and financing. The third pillar of STEP is to ensure essential services and include provision of food security and nutrition, access to basic services, cash incentives for workers, and finally recovery and economy efforts. Due to time constraints, the following issues and achievements will not be discussed, but the overall lessons and recommendations include supporting countries in the development and implementation of national plans which are developed in partnership stakeholders is crucial in building both resiliency in the face of future emergencies and in the longer term the capacity to provide universal access to safe, high-quality healthcare services. Furthermore, stronger governance and economic support should be the paramount in prevention and management and recovery of any outbreak. The fourth pillar is to preserve stability. It ensures availability of reliable supplies, material and equipment, transport and fuel, and social mobilisation and community engagement. And finally, messaging. As noted in previous areas of STEP, availability of resources and transport became a major issue during the outbreak due to road closures, quarantine measures, and poor governance. The main lessons learned included facilitating logistical coordination and establishing strong communication systems. Finally, social mobilisation, community engagement, and messaging were overarching themes which could be suggested as the main issues, achievements, and learning curves taken from this epidemic. Many prior pillars were met with issues due to poor communication and collaboration with communities, and it was noted that it wasn't until service providers became responsive to community concerns and needs did trust and understanding emerge. By the 31st of December, a situation report conducted by WHO singled out community resistance to response measures as a major barrier to outbreak commitment. It is now clear that social mobilisation and community ownership coordinated by leading agencies is crucial in behaviour change and communicating information. The final pillar is preventing outbreaks in other countries unaffected. In accordance with the IHR, WHO maintained global alert and response readiness activities to strengthen worldwide event-based surveillance and reporting of signals of potential Ebola cases through focal points and via independent monitoring and risk assessments. During the outbreak, Ebola spread to 7 countries, but all cases were controlled and transmission stopped. Preparedness activities aimed to ensure all countries were ready to safely and effectively detect, investigate, manage, and report potential cases and mount a rapid and effective response. An Ebola preparedness checklist was created and was based on lessons learned from the 3 most affected countries, as well as the experiences of other countries responding to imported cases. Shared communication and information using internet searches and regular meetings were found to be successful and is recommended for future epidemics. Furthermore, training courses, workshops, and simulation exercises are recommended to review capacities firsthand and provide direct support. Finally, identifying and training partners in wildlife data collection and conducting risk assessment of virus spillover from animals to humans will assist in formulating risk management strategies. In conclusion, from this review, it can be noted that the rapid growth and complexity of the 2014 epidemic took organizations like WHO by surprise. Evidence suggests that the changing distribution of animal vectors, population density, mobility, lack of trust in authorities, and poor community engagement were the main drivers for this unprecedented spread of the disease. Furthermore, the epidemic revealed all 3 countries' pre-existing challenges in their health systems with inadequate infrastructure. The UN MARE was a final solution led by the UN after the response roadmap. A classic outbreak control measure did not suffice the response needed. It was initiated in the late stages of the epidemic and can be seen that the 5 pillars guided was successful in controlling the outbreak. UN MARE attempted to coordinate responsibility and learned crucial communication and community engagement strategies to overcome distrust and rumour generation. Despite a somewhat new whole system approach, UN MARE was criticised for carrying out the response as if it was a peacekeeping operation, transporting vast quantities of food rather than medical supplies and pushing logistics operations of little value to medical crisis. The next slide shows overall lessons learned and recommendations for future pandemics, which include 4 main areas: prevention, response, research and development, and systems and governance. Thank you.